Yes. What? What is the WhatsApp? What is the link? Did you press the link? Wait, give it to me. Why did you close it? Again, we have to review your mobile. We can enter in this way.
Yeah. I will do there though.
Yeah. Yeah, here, go before and because you will be the last.
If I want, because I will show them the equipments, I will exit the share like that, so they can see me.
Yeah. Okay, wait. I accept it. Then we'll give you admit. We'll give you the Madonna. We'll give you the if you want to show the floor.
Okay.
Madonna, can you start? Just share your screen, please. Can you start, please? Just share your screen. Share your screen. You need help?
Yes, Doc. Okay.
Just click on the share screen and then click on the presentation. Yes.
It's showing already, Doc.
Yes. Click on the presentation and start. Click on the presentation, Madonna.
Okay, Doc.
Yeah, let's start.
Good morning to all of you. I will present to you today about UAC and UVC guidelines. UAC, umbilical arterial catheter, and UVC is umbilical venous catheter. So the purpose of this lecture or discussion is to provide standard practice for physicians and nurses during placement and removal of the umbilical catheter. So in order for us, nurses and physicians, to be competent in inserting UVC and UAC catheter. So we have 2 arteries and 1 veins. So don't forget the word AVA, 2 arteries and 1 vein.
Your is not moving. Can you stop and start again? Your slides are not moving. Can you stop sharing?
It's okay now, Doc.
Your slides are not moving. Can you stop and restart sharing?
Okay, Doc.
Stop sharing. Yes.
Now
So
moving.
do present. Click on presentation.
It's now okay.
No.
Still?
Yes. It's not moving. Just let me help you 1 minute.
Okay, let's proceed.
Go ahead.
What is umbilical? Now it's okay, Doc.
For some reason, we're seeing your non-presentation, not the presentation. Yeah, go ahead. Anyhow, move.
You're seeing or what? Yes. Okay. Umbilical artery. What is umbilical arterial or venous catheterization? It is a method of insertion of umbilical catheter through the umbilical artery or umbilical venous of a neonate for a certain indications and specifications under strict sterile technique. So it means it is a procedure that we should have strict sterile technique to make sure that the equipment and the areas are free from all microorganisms and to maintain sterility, complete elimination of the microorganisms. So it's very important to have strict sterile technique in this procedure. So UAC and UVC insertion purpose.
Yeah, again, it's not
So-
moving. So can you send it to me? Send me the presentation. I'm going to present it from here. So stop your sharing and send it to me on your email. I will present it from here. Because it's not moving. Yeah, now it's moving. Yes, yes. Now it's moving. Just send me, I will present it, huh? Madonna, send it to me, to my email or my WhatsApp. Because it's not moving. Don't know why. Maybe your internet is not good, your connection is not a problem. There is some issues. Can you send it to me? I will present it. Okay? Just send it to me. But come to my room, come here. Which email? This one? This one? You can sit here. Close the other one. You can sit here. You can present from here.
You will click to private audio.
No, you can speak and present from here. I'm gonna.
Okay.
Yeah, just come here. Do you guys see the screen now? Yes.
So I will bring this.
No, you can come from here. Oh, okay. You guys see the screen? Hello? Anybody? Do you guys see the screen? Anybody? Any response?
Yes, sir.
You see? Okay, thank you. Later. We'll do the workshop later. Just come and present. Madonna, leave everything. Just come and sit here. Just leave everything. No, just present. We'll come out there. Yeah. Go ahead.
So I will start again.
No, it's okay. What did you reach?
No, I will start.
Oh, where, no, you can reach, but yeah. So, go ahead, I'm gonna move. You reach here.
Yeah.
Oh, just click here. Yeah, go ahead.
So what is umbilical arterial or venous catheterization? It is a method of insertion of the umbilical catheter through the umbilical artery or venous of the neonate for a certain indication and specification under sterile and strict sterile technique. As what I have said a while ago, in this procedure, we should maintain a strict sterile technique to prevent infection. So UAC and UV insertion purpose. So as you can see in the pictures, there is the two arteries and one vein. The vein is in the middle and then the both sides are the arteries. Then there is the Wharton's jelly and then the cord lining. Then the initial purpose of a UVC and UAC insertion is for emergency access and stabilization of the newly born when peripheral intravenous line access is not possible. As we all know, as we are catching babies in LDU and in OT, we first try to insert peripheral line. If it failed twice, then urgent UVC and UAC insertion should be done in NICU. And then one of the purposes is to infuse drugs and fluid during resuscitation. And of course, it is applicable for extremely premature infants or seriously ill infants, neonates. So we can differentiate umbilical venous catheter indication for placement of UVC and UAC. For umbilical venous catheter, we need this UVC for medication, administering of medication, EPN, and IV fluids. If there is also inadequate vascular access, we need to give prolonged IV antibiotics and for exchange blood transfusion. We need this one also when the neonate's weighing is less than 1,500 grams. And of course, with neonates with GI problems, congenital and cardiac disorders. So, but except if the neonates has GI problems like omphalocele, and peritonitis. In UAC, it is used also for continuous monitoring of blood pressure. For continuous vasopressor, we are giving vasopressor like dopamine, epinephrine, and norepinephrine. This continuous monitoring of blood pressure, we are connecting the UAC into the transducer that is connected in the monitor. Also for exchange blood transfusion. And for frequent or continuous measurement of partial oxygen. Why we need to measure partial oxygen? We need to measure the partial oxygen to evaluate respiratory distress, then the condition that can affect the lungs. So we can decide if we need oxygen supplementation or mechanical ventilation. As you can see, UVC, UAC. For medication, EPN, and IV fluid, we cannot give via UAC. We cannot give via UAC because it can cause like necrosis if we will put in UAC, and there's some tendency also that we can cut the limbs of our neonates, if I am not mistaken. And then UAC and UVC placement contraindications.
You already mentioned that.
Yeah. So omphalocele, omphalocele. Omphallitis is the infection of the umbilicus. Omphalocele, the organs are outside. Then necrotizing, this is the commonly necrotizing enterocolitis. As you can see, here are some sample images. So this is the example of the omphallitis. Then this is omphalocele. The organs are outside. Then peritonitis. This this is the neck. Necrotizing enterocolitis and then peritonitis. So potential complication of UVC and UAC placement. So as you can see, we can differentiate. The number one complication is infection. So in order to avoid sepsis, a UVC should be placed. Keep no longer than 14 days. Ideally, we should remove 7 to 10 days. For UAC, we should keep no longer than 5 days. And then catheter malposition in the heart or liver, and peritoneal perforation and bleeding. Also in UAC complication, we have vascular accident, hypertension, air embolism, and bleeding. So the vascular accident like thrombosis, embolism, and vasospasm. So this thrombosis, if there is thrombosis, there is blood clot that blocks the vein or the artery. If we will say embolism, the clots already stuck on the bloodstream that prevent the blood flow going to the extremities or blood vessels that obstruct the blood flow. Cardiac arrhythmias also for UVC placement and thromboembolism. So what are the equipments needed? We have the umbilical catheterization set. We this include the umbilical tape, antiseptic solution, the forceps. Later, we will show all the equipments needed.
Yes.
Later, doctor. We will show later.
Later.
So later, there is workshop under Dr. Yahiya. We will show all the equipments needed. So you can see the specific, what is this? Equipments.
Yes.
So we have umbilical tape, antiseptic solution. We are not using betadine anymore, only alcohol swab, or we have this swab we are using for blood culture. We can use that one. Then forceps, for the forceps, we have the mosquito forceps, curve and straight. And
Just we are not using the betadine to prevent the damage of the skin.
because
Release less than 1500 grams.
to prevent irritation and to prevent skin peeling also. And then we have forceps, the forceps with teeth and forceps with tooth, and then the scissor also, we need that one, scalpel, and then of course the 3.0 self suture in a small curved needle. So we are putting 230. So there is extra because sometimes you have difficulty suturing, so doctor need to 230. And then of course umbilical catheter. Also we need dilator, that's long one, to dilate the UVC and UAC. Umbilical vein, I mean an umbilical artery. Umbilical catheter, we need French 3.5 or French 5 single or double lumen, and then for French 2.5 we have the single lumen. Sterile barrier, of course, we need draped sterile gown, gloves, the size of the doctor, 7.7.5. This one should be powder and latex free to prevent irritation also if there's some allergy of the neonates. Of course, cap and mask. Also, we are not using now chlorhexidine for the skin cleansing. Then we need heparinized saline, 0.5 I use. This heparinized saline, we are using normal saline plus heparin. And also later we will show you also the dilution. Syringes 1 ml, 3 ml, and 5 ml. Also 1 heparinized saline for taking blood gas, EBG, VBG. But usually we are doing capillary blood gas. And then this needle-free access valve we are used for both UAC and UVC. That one, the small one, as you know all already, that one. Then umbilical tie, and then the three-way stopcock. We are using the three-way stopcock on UAC, and then this 3 IV extension line, 3 lumen. We are using that one for UVC. And then the umbilical catheter holder. Of course, sterile gauze we need, and then the this is the one I am telling, arterial line transducer. This one we are connecting to UAC to monitor the continuous blood pressure, accurate blood pressure of the neonates. And then also we have the IP connector. This is the connector cable connected to the monitor through the UAC transducer. And then here is a heparinized saline dilution. First, we need 1 ml of heparin. 1 ml is equal to 5,000 IU. Then we will take on that 1 ml, we will take 1.1 ml is equal to 500 IU. And then take 1 ml of 0.1 ml of heparin plus 0.9 ml of normal saline is equal to 1 ml of heparinized saline. Typo error spelling, sorry. 1 ml is equal to 500 IU, so equivalent to 0.5 ml is equal to 250 IU. So take that 0.5, dilute in 500 ml of normal saline, so it will go 1 ml per hour. That is the standard to be run 5 IU. But Dr. Yahia told we are only giving via UVC 0.5 ml per hour. But if there is TPN, we are incorporating the heparin in the TPN and IV fluids. For UAC, we are running 0.8 ml per hour.
Well, this is the minimum. We can go higher if we need, if we have a room for fluid. If you're fluid restricted, this is the minimum, otherwise the catheter will be full.
Okay. And then measurement and positioning of the umbilical catheters. So we can differentiate again umbilical venous catheter and umbilical arterial catheter. So for UVC, we are using French 3.5 double lumen if the infants weighing less than 1.5. And then French 5 for the infants weighing greater than or equal to 1.5. While in the UAC, we are using French 2.5 if the infants is less than 1 kilograms, and then French 3.5 if the infant is weighing greater than or equal to 1 kilograms. As you can see, the French of the UVC is bigger than the UAC. Then the placement. For the UVC, the correct position is at the level of the diaphragm. And then for UAC, between thoracic vertebrae 6 and 9. For the measurement, measure the distance from the, as you can see, from the umbilicus to the xiphoid process and add 1 cm. As you can see in the pictures like this. And then UAC, measure the distance from the umbilicus to the mid should be the mid-clavicular joint of the shoulder. So the formula we have in UAC 3 times birth weight in kilograms plus 9, and then here in UVC 3 times weight in kilogram plus 9 divide 2 plus 1. So central UVC should be confirmed. The diagnostic test is via X-ray. It should be at the level of the diaphragm and below the heart. So here is I cite some example of measurement and positioning of the umbilical catheter. For example, we have currently Sajida, baby boy Sajida, our current patient. We did UVC and UAC. The weight is working weight is 1.1 kilogram. So 3 times 1.1 plus 9. So it's equal to 6.163 plus 9 is equal to 12.3. And then in the UVC, as you can see, birth by 3 times birth weight plus 9, that is the UAC length, divide 2 plus 1. So 6.5 plus 1, then 7.7 cm. As you can see, guys, the length of the UAC is greater than the length of the UVC. So you can differentiate.
Almost double.
Yeah, it's almost double. So confirmation X-ray again, and the should be at the level of the diaphragm and below the heart. So doctor's physician test was discussed already by Dr. Marwa, so I will discuss the nurse's responsibilities. So first, we should identify the correct patient by checking the ID band. What we will check in the ID band? The complete full name and the MRN number of the neonates. And then, of course, as I said before, gather all the equipments and supplies needed. Then check vital signs prior to the procedure and connect to cardiac monitor. Always keep in mind that before starting procedure, we should check vital signs and always connect the neonates to the cardiac monitor. And then for complete a safety pose prior to procedure, we will this pose we will think if we prepared all the equipments needed, if we are ready, and then if we did the sterile technique. Then 5, place sterile procedure in proper sign on the closed door prior to the start of the procedure and illuminate the purple light on the nurse call system outside of the patient room. So this means that we should put a signboard that the sterile procedure is ongoing, so no one can enter in the room if they are not wearing the proper PPE. Proper PPE should be they are wearing gown, mask, gloves, complete sterile PPE. And then 6, before preparing the cord and skin, we will make external measurement. So this is the one we should measure how much is the length of the UAC and UVC. And then sterile technique is used by hand washing. Surgical hand washing should be surgical hand washing 1 to 3 minutes hand washing like we are doing in OT, and then wear sterile gloves and sterile gown. And then make sure, this is important, make sure everyone present during procedure should wear a cap and a mask. Then make sure also that the observation checklist is completed in effect during the procedure. That we have checklists, and then we should check that one is all complete before starting, during, and after also. And then after the catheter position has been confirmed and medical healthcare provider has sutured the line in place, secure also umbilical catheter to abdomen with the adhesive tape umbilical catheter holder. Make sure catheter markings are visible. For example, 12 cm, it should be visible. We can see that one. Then 7 cm also we can see. And then maintain patent airway of neonates. So while doing before, during, and after, we should maintain patent airway of the neonates. For example, the patient is ventilated, especially very important, if the patient is ventilated with ET-TIL, we should check always if the baby is okay. Like if the monitor, just an additional information I want to share, if the monitor is having high pressure, that one there is some obstructions, maybe secretion. So we need to know that one. We will check the saturation monitor, there attached saturation probe. And then if the ventilator is low pressure, there is disconnection. So we need to check also. So just remember the HOLD, HOLD, high pressure, obstruction, low pressure, disconnection. And then do aftercare of the equipments and properly remove PPE and hand washing. So we need to check Also, after procedure, if all the equipment is complete, and then we should properly dispose, remove PPE, like doffing and gowning. So doffing, we should remove first the gloves, and then the cap, and then the gown, and last is the mask. Then documentation. Documentation should be done before, during, and after procedure. So what we will document? So date and time of the insertion, the site of insertion, UVC and UAC, the size of the catheter, the length, and the condition and vital signs before, during, and after. Then make sure also the maintenance checklist is obtained and filled out every shift. I will show you later all the documentation.
So the best way to document, Madonna, is to have another person
Yeah,
So, observing and
Yeah.
documenting. So
Yeah.
we can document
Yeah.
nurse number 2 or
Yeah.
number 3,
Yes.
whatever. Just observing.
Actually, maximum person should be present in insertion of UVC and UAC is one doctor or consultant should be there for standby. If failed, he can try. And then 2 or 3 nurses, one is scrub, one circulating, and then the other is help. And then also, if there is oozing in noted from the umbilicus, oozing means there is some leaking like that. It's a sign of infection. So this one, there is a policy for that. Later, Dr. Yahia will discuss, but the priority nurse action, if there is oozing, we should report immediately to the doctor. And then once avidin is placed, avidin is this hemostat. Later, you will see that hemostat. A nurse must visualize and document the site every 15 minutes. We are using hemostat or avidin to stop the bleeding for hemostasis. So documentation, first, we need the consent, high risk consent. As this is our current patient. For a demo only, we use this current patient. So we inserted this one last, consent was taken last August 1. So there is doctor, witness, and doctor's signature. UV insertion, infection, and bleedings, as you can see. Then the father signed there. This one should be thick, guardian. And then here is the surgical safety checklist. So before, sign in, before induction, anyway, we didn't, no anesthesia was given. So patient has confirmed identity, site, surgical consent, procedure, UVC insertion. Is the surgical site marked? Not applicable. We are not marking. And then is the patient on pulse? Yes. Oximeter attached. Not applicable for anesthesia machine. No allergy. Difficult airway. There is, the baby is on CPAP. So yes. Risk of less than 500 ml of blood loss. No. And then the time, date, and then the location. Date also should be written. Then time out to be read loudly by the circulating nurse. Confirm all team members introduce themselves by name and role. Surgeon, the nurse also, then patient identification, comparing file and ID band, procedure, site, and position. Is one supine position. And then anticipated blood loss. And then requirement special investigation is available. We will take CBC, RFT, then blood culture. Then critical anesthesia, not applicable also. Is sterility of the instrumentation been confirmed? Yes. Are the equipment issues are concerned? Yes. As the baby receive antibiotics before? No. Essentially, image not applicable. And then date and time. Then sign out. Registered nurse verbally confirmed with the team. The name of the procedure recorded. Instrument, sponges, needles, counts. You should count, yes. And then the specimen, no, not needed. Then date and time. Then the surgeon will sign here. And then the scrub nurse. And then circulating nurse. This is the surgical checklist, this marking side. Yes. We didn't mark only for the demo purposes, but in the patient, we didn't mark that. Then this is the central line bundle
Yes.
checklist. So proper central line insertion practices. Perform hand hygiene before insertion, yes. Adhere to aseptic procedure technique with appropriate hand hygiene, yes. Use maximally sterile barrier precaution, example glove mask, yes. Perform skin antisepsis, alcohol swab only we are using. You should, the best insertion site, avoid femoral site. Also sterile was with.
So these are central lines in general, not
Yeah.
like specific umbilical.
Yeah, in general.
It's a
This is our checklist.
So that's why they are telling you avoid.
Yeah, yeah. And then comply with the aseptic. Then we should, every day, we should check. So this 2 days only because UVC already removed at August 1, 10 a.m. So comply with the aseptic technique, yes. So scrub the access. If we are giving medication, we always wipe first with the alcohol swab prior giving medication. Then access catheter only with sterile devices. Replace dressing if there is soil. We will check also if there is leaking, dislodge. Then perform dressing changes under aseptic technique using clean sterile gloves, and then perform daily audit to access with whether each central line is still needed. As we can see, if UAC should be not longer than 5 days, and then UVC should be 7 to 10 days only. Should be central line inserted by Dr. Rehab, central line removed by Dr. Haron, and then nurse should be signed here. Then catheter removal. So if we will remove the catheter, gather all the equipments needed for removal. We have the removal kit and the PPE. Again, sterile. Even we will remove only the catheter, we should perform sterile technique. Use PPE, always sterile PPE. And then identify the number on the catheter at the point that it exceeds the umbilical cord and compare that with the documentation in the patient chart. So we should see the length of the catheter because if 7 ml, it should be complete, not cut. So maybe some catheter will remain on the patient. Then perform hand hygiene, maintain sterile technique, wear proper PPE, and use alcohol-based waterless cleanser. So always, guys, sterile technique to prevent infection. Hold the umbilical cord securely with the forceps and cut the sutures with the scissors, taking to cut the catheter itself. So avoid to cut the catheter. And then place one hand gently on the abdomen at the base of the umbilical stump to provide stability. Use the other hand to pull out the catheter in a slow, about 2 minutes and steady manner. Anyway, later Dr. Yahia will show you that one. Like we will hold and then we should slowly pulling out. Avoid pulling that catheter abruptly. It should be gradually slow.
Yeah, if you abruptly, you can cause vascular instability first, and second, you might cause damage,
Bleeding
or you might cause crack, or even loss of the piece of the catheter. So it's not like very, very rare to leave the piece of the catheter inside because of improper pulling. Never use force. Be patient and slow when you take it out.
Then next, use sterile gauze to hold pressure on the umbilical stump after catheter is removed and ensure bleeding has stopped. So when we remove the catheter, we should compress, put pressure to stop the bleeding.
So you remember that when the catheter is inside, especially the venous, it's been dilated a long time, so you want to know those vasospasm might keep bleeding.
bleeding.
And remember, pressure can stop any bleeding, so you need to press for a time, and then observe it after that, whether you need a continuous pressure or you just need to observe.
The next is if oozing persists, there is hemostat may be applied to achieve hemostasis.
So we have a guidelines for controlling oozing. We'll speak about oozing on this separate guidelines.
Then inspect the umbilical catheter to ensure that it's intact.
Very important. It has a
Yes,
crack
very important.
or it has like a missing piece. Very important.
Then, of course, document the UVC removal procedure in the infant's electronic medical record and include the catheter length. So we should document all what we've done to the patient and also the length and the catheter if it is intact. And then removal of UVC should be considered when 100 ml per kg per day of the enteral fit is reached or after 7 to 10 days. As what we told earlier, to prevent infection, UVC should be 7 to 10 days. UAC should be not longer than 5 days. And then you should be considered day 3 and day 5. But if we need longer time, it's up to the doctor if they want to keep that UVC and UAC. And of course, we don't forget to charge all the supplies we use by Mary and Rizan.
Thank you very
Thank
much.
you.
Very
Then
welcome.
this is the picture of our current patients.
You should not show the face.
Only for us. I cannot see the pictures on here. This is the previous one.
Thank you very much.
Thank you.
Thank you. Thank you very much. Any question? Anybody has any question to Madonna?
Don't be hesitant to ask questions. Dr. Yahiya is here to answer all your questions.
You can answer too. Any question? Okay, so in a few minutes, we will do a video and then send you the video. We'll do some demo for those who are attending. Thank you.